Good afternoon, everybody. Welcome to HSR UK 2022, and many thanks for taking your time and showing an interest in my presentation. Unobserved confounding and impact evaluations of multidisciplinary teams using administrative data, thus accounting for household context factors lead to better effect estimates. This is a joint presentation with my colleague Therese Lloyd at the Health Foundation. I'm a senior statistician working for NHS England, and we are both members of the Improvement Analytics Unit. I'll start by providing you with some background to this particular piece of work. I will then move on to overviewing the motivation for the study. I will then outline some broad results and conclude with some remarks and interpretation notes. By way of background, in July 2015, the North East Hampshire and Farnham, henceforth NEF, Clinical Commissioning Group, was awarded by NHS England NHS Vanguard status, specifically PACS, Primary and Acute Care System. As part of this setup, the CCG also proceeded by rolling out an enhanced package of healthcare improvement measures, one of them in particular to its to the population it's got responsibility for healthcare of. In particular, one such initiative consisted of MDTs, multidisciplinary teams, cross-cutting a number of healthcare sectors, notably primary care, voluntary sector, mental health services, social services, community care. Such teams would meet on a weekly basis to discuss patients referred to them individually and produce in a coordinated fashion a healthcare improvement plan for each of them. Normally, referral to said teams would take place on a clinical, somewhat to some extent subjective judgment basis, as carried out typically by a GP or a healthcare specialist. Referring clinicians would normally base their referral decision or clinical assessment on the grounds of the degree to which they considered their patients to be vulnerable or at especially heightened risk of a healthcare crisis. As such, the idea being that such individuals in particular would especially benefit from the support offered by an MDT. Among stated aims for such initiative was obviously the improvement of the healthcare and the well-being of the recipients, their improved self-confidence and healthcare management, and also a reduction of their emergency hospital activity, notably emergency admissions and A&E attendances. Now, in September 2018, the Improvement Analytics Unit published and is available on the Health Foundation's dedicated webpage, an impact evaluation whereby statistically significant evidence was found of an increased utilization of emergency hospital resources by people referred to an MDT in NEF compared to a carefully selected matched control group. This finding is not as counterintuitive as it might seem. Indeed, there is accruing mixed evidence of the impact exercised by MDT or more broadly integrated care initiatives on emergency hospital activity among their recipients. One of the possible explanations for this has to do with MDTs essentially uncovering and to some extent possibly over-medicalizing unmet medical need. Another possibility has also got to do with some unobserved confounding affecting the original evaluation. Again, this would not be surprising in that impact evaluations typically rely on observational retrospectively collected data, and as such are inevitably prone, at least to some extent, to hidden bias, essentially bias exercised by variables that have not been observed or are not observable. Now, since the publication of such evaluation, the EU has developed two so-called household context factors, two binary variables consisting of one, whether a given individual, a given patient lives alone or not, and two, whether a given patient who lives in a two-person household lives together with a person who has a diagnosed frailty condition. Such indicators have been derived with the help of the National Commissioning Data Repository, NCDR, which stores information pertaining to the GP registration of patients in the country, notably derived from the minimal master patient index, as well as unique physical address identifiers called UPRNs, unique property reference numbers, covering the whole of the UK. Both these variables we regard them as representative to some extent to social isolation, possibly predictors of social isolation specifically. In particular, the living in a two-person household with somebody diagnosed with a frail condition can also be seen as a proxy for having informal caring responsibility for that particular person. Now, the IAU has conducted a study published a few months ago in BMJ Open at national level involving the cohort of individuals living in Britain of 65 years of age or over, and examine the link that their hospital resource use has with the household context factor I've just introduced. This study uncovered an unequivocal, statistically significant, rather strong link between hospital activity and household context factors. This is summarized in the table you see in the lower right corner of the slide, whereby essentially hospital activity increases by 9 to 14%, depending on which kind of hospital activity is considered, any attendances or emergency admission, and which kind of household context descriptor we are referring to. The sheer size of the study, around 0.4-0.8 million individuals, explains the very accurate degree, the high degree of accuracy of these estimates. This is the driving motivation of us revisiting the NEF 2018 evaluation. In essence, the idea being that by incorporating household context factors into the evidence-based underpinning that evaluation, there might be the possibility of obtaining revised effect estimates for MDTs onto the recipient population, revised by the fact that such household context factors might account for some, at least, unobserved confounding that may potentially have been affecting the original evaluation. In terms of methodology, we had to take a couple of departures from the original study. To begin with, we improved on in particular the care home residency status variable, and that was had simply to do with the fact that the algorithm providing this information has since been improved and has increased its degree of accuracy. Another element of originality we have of the original evaluation has in the approach for building the counterfactual. The original evaluation adopted an approach called genetic matching, which is a modern matching algorithm, which is quite effective and flexible. However, it suffers from quite slow run times when it's applied onto large data sets. In our case, we are talking to the order of 450,000 control units against 773 intervention units. An approach we adopted quite successfully to overcome this computational issue consisted in combining a matching approach, a faster one, optimal matching, with a weighing approach called entropy balancing, quite a modern one as well. And the combination actually proved to be quite successful. We then proceeded, similarly to the original study, with estimating effects on outcomes by fitting outcome regression models to the weighed matched control sample that I just outlined derivation of. All stages of the analysis were replicated with the pool of covariates informing them, including and excluding separately the two household context factors for comparison purposes, and obviously relied on an array of covariate information, quite rich covariate information, capturing elements of socio-demographic, economic profiling of the patients, their long-term conditions, prognostic factors, and past emergency hospital activity. We also carried out, aside from the base case analysis, also some subgroup analysis, notably but not exclusively around people living alone and around people living in two-persons households with somebody diagnosed with a frail condition, consistently with the two household context factors. Main results from the revisit evaluation are in the 2x2 table you see on the left-hand side of the slide. In essence, consistently with the original evaluation, a statistically significant increase has been noted in emergency hospital resource utilization among people in NEF in receipt of a MDT in the period July 15 till May 2017, relative to the matched weight control group. But what is significant to observe in this case, aside from the consistency from the original evaluation, which was not surprising, of course, is that inclusion of the household context factors in the analysis hardly mattered. The extent, the magnitude and sign and degree of uncertainty attaching the effect estimates is virtually unchanged. The same, in essence, can also be claimed around the subgroup analysis we carried out, where little to no difference had been observed, whether the analysis was informed with or without the household context factors. Where does this leave us? Well, some explanations can be found as to how is it that household context factors didn't seem to have an influence on the impact estimates surrounding the NEF-MDT evaluation. One possible explanation that is worth mentioning has to do with the fact that upon building the counterfactual, when not using the household context variables, we noticed that the matched weight control group was still actually quite well balanced in terms of the two household context factors themselves. So in essence, it may not be as surprising that in the end, we did not find out that there was, that there could have been an effect there. Another consideration, which is more conceptual, has to do with the link between the household context factor and the wider concept of social isolation for a given patient. So the idea here being that if, as we do suspect, the referral decision into an MDT by a clinician is driven or influenced by the degree of social isolation of the patient, then maybe the household context factors we've identified in the unit may not be, may only be imperfect or too imperfect descriptors of an individual social isolation. So there might be this component. Another component, and as a consequence of this, it might be the case, again, if social isolation drives an MDT referral decision, that the comparison groups of the evaluation are imbalanced in terms of not so much household context characteristics, but rather social isolation itself, meaning that the intervention group may be overrepresented relative to the control, matched weight control group, in terms of social isolation, which once again, we may not be doing a great job at extensively capturing. In the end, the BMJ open study still indicates a very strong, a rather strong, and a substantial and statistically significant association between emergency hospital resource use and household context factors. So where does this take us next? Where is it that we do feel that this sort of information can be used to valuably inform social and policy research? Well, for one, we suspect that it might be worth relying on this information to underpin studies that have to do with initiatives or healthcare improvement programs whereby the referral decision may be influenced by the degree of social isolation of the potential beneficiary. But on the other hand, social isolation is not explicitly stated as a referring condition, as a eligibility criterion. Another kind of study that we do think it's worth including in terms of research, and it's worth including household context factors in terms of research, is certainly population health management studies, like for instance of personalized care. This concludes my presentation. I'd like to take the opportunity to thank you once again for giving me your time and your interest in this piece of work. Once again, I would like to thank my collaborator on this piece of work, Therese Lloyd, the wider improvement analytics unit, who at different times and to different extents significantly chipped into this work. That's it.